I am Dr. Theo Theoharides. I'm a professor of neuroimmune medicine at Nova Southeastern University. I'm delighted to be Dr. Eleanor Stein's actually podcast. We had a wonderful time together, and three major takeaway pieces is, number one, the mast cells are everywhere and can be stimulated by numerous triggers, not just allergens. Number two, they can release as many as 300 molecules, and we cannot block 300 molecules. Therefore, it's very important to block the mast cells from releasing. Number three, there are natural ways to attack, if you wish, the mast cells, including some flavonoids in liposomal form, as in those produced by the company Algonaut, and it usually takes 3 months for the mast cells to calm down.
Welcome to the Dr. Eleanor Stein podcast. In this show, you will hear expert medical professionals, researchers, and people with lived experience share science-based, low to no cost strategies to help people with complex chronic diseases. Listen in for another dose of education, empowerment, and hope. Hi, everybody, and welcome to this episode of the Dr. Eleanor Stein podcast. This episode is of interest to anyone who has apparently random flares of symptoms that take days to weeks to recover from, people who become sensitive to everything, and people who want to know more about whether they might have a potentially treatable driver of their symptoms. We're going to be talking about MCAS, mast cell activation syndrome. Now, I personally became interested in MCAS early on, and my interest increased dramatically when I was diagnosed with it myself by none other than Dr. Lawrence Afrin, one of the clinical experts in the field. So it is my pleasure to welcome to this podcast, I'm going to try to say his name correctly, Dr. Theo Theoharides. Perfect. Okay. For many of you, he needs no introduction. He's probably one of the most productive researchers in the field of MCAS. He's a PhD, an MD, an internist, and he has specialization in allergy and immunology. He's currently the executive director of the Center for Excellence for Neuroinflammation Research at Nova Southeastern University. And for many years, he was the director of molecular immunopharmacology and drug discovery at Tufts University. He's been studying mast cells way before any of us had ever heard of them for over 30 years. He's published, probably even today, it's up to 500 publications. And he's one of the most cited authors worldwide in all fields, but he's definitely at the very top when it comes to mast cells. Not only is he a researcher, but he also creates and invents things. So he's the holder of over 30 patents and trademarks, including a patent on products that treat brain inflammation. So Dr. Theoharides.
That's Dr.
I'm going to get it by the end. I'm very determined. Welcome so much, and thank you for generously giving your time to share your knowledge with us.
Sure. Dr. Stein, it's an incredible opportunity. Thank you very much for inviting me. I congratulate you for all your efforts getting the word out there.
Thank you so much.
Towards the end, I'll mention a few websites
Okay.
that might be helpful to everybody. But to start out, I would encourage whoever wants to visit YouTube and go to the My Mystery Symptoms and Mast Cells. So it's a video they recorded actually in Denmark with two patients. One was Danish, the other was American, and presents their symptoms, how complicated they are, and we weave how mast cells may actually be involved. That was done almost 50 years ago, but I think it's one of the simplest ones that also include patient perspective rather than just me or someone else talking.
That's great. Okay.
Thank you. I'm also, happy that you visited my good friend Larry Afrin.
Yeah.
Larry is a great clinician, and his approach to mast cell activation is a little different maybe others, but I'll bring the crystals down in a few minutes.
Okay.
So before we talk about mast cell activation syndrome, I need to make sure everybody understands that there are 4 different categories of mast cell activation. So the first category is when we have too many mast cells in our body, in which case it might be systemic mastocytosis or cutaneous mastocytosis. And what is interesting is in systemic mastocytosis, pretty much everybody has mast cell activation. In cutaneous mastocytosis, hardly anybody has mast cell activation. So go figure how the muscles can be very different depending on the tissues. The second category is the bread and butter of an allergist. So it's allergic conjunctivitis, allergic rhinitis, eczema, things of that sort, itching, chronic urticaria. The third category is what medicine doesn't know what to call them. We call them idiopathic. So you have idiopathic anaphylaxis, idiopathic, angioedema, and you have idiopathic mast cell activation. Now here comes the tricky part before I talk about the fourth category. The tricky part is that according to most everybody, maybe with the exception of Dr. Rafferty and myself, in order to have mast cell activation syndrome, you have to have serum elevations of this enzyme that is unique to the mast cell called tryptase within 48 hours of an episode. But unless you have an intravenous catheter, there's no way anybody will draw blood. And most emergency rooms don't know what the hell we're talking about when we present. A parenthesis here, I had actually a physician reach out to me a few months ago because his wife had reactions that were clearly, to me, indicating mast cell activation. They went to a major hospital in Florida, and the emergency room physician asked his wife, "What's wrong with your breasts?" So just the word mast cell activation to them, still.
Oh my gosh.
Just that breast. You can see how way far behind we are, let alone the nuances that we will be discussing in a few minutes. So if tryptase is elevated within 48 hours, and you have all the other telltale signs of history of reactions, et cetera, you have mast cell activation syndrome. However, if you don't have tryptase activation or tryptase elevation, then the question is, what do we call it? Well, there are 2 other diagnostic codes other than mast cell activation syndrome. One is mast cell activation unspecified, and the other is other mast cell activation disorders. And in all honesty, many of the patients I see do not have mast cell activation syndrome. They have either one of the other 2 categories. And it is easier for me to deal with and explain it to the patients because many times tryptase is not high and they'll say you don't have MCAS. I know my friend Larry Affrey will say you still have MCAS because of the criteria he set up. But we have to at least know that there are other diagnostic categories that exist in Canada as well that can still qualify a patient for doing testing and potential treatment options without necessarily sticking to the MCAS specifically. Okay. So what are the symptoms? Yeah. Basically, we think of the mast cell as a soccer ball filled with about 500 to 1,000 ping pong balls, each ping pong ball having about 100 to 200 molecules. So if the mast cell is activated, let's say in someone who was stung by a wasp and went into frank anaphylaxis, then it will explode like a head grenade, will release pretty much everything. And unfortunately, we'll only deal with histamine and maybe leukotrienes, 2 sets of molecules, and tryptase. In most other cases, the mast cell can release molecules without histamine and without tryptase, which is what I call the 4th category of mast cell activation. Let's take it back a step. So let's say someone has allergic asthma. Allergic asthma is a chronic condition. If the mast cells are activated because we breathe some allergen, they will fire within a minute to 5 minutes and will release the granule content, which might be all of them or some of them, such as histamine, tryptase, tumor necrosis factor, etc. Over 6 to 12 hours, however, in asthma, there will be release of other molecules that are newly synthesized, and most of them are what we call cytokines. They're pro-inflammatory molecules. So,
and does these additional late forming molecules are they in the mast cells or they're now part of the immune activation?
No. Absolutely part of the mast cells.
Okay.
So for instance, tumor necrosis factor is a pro-inflammatory cytokine. Mast cells are the only cells in the body that pre-form and store it ready-made. In every other cell type, it has to be triggered. The genes have to be activated to make it. Molecules such as leukotrienes and prostaglandins are synthesized immediately upon activation of the mast cell and are released, but they aren't preformed. And then you have the slow release of many, many other molecules, such as interleukin 1, interleukin 6, interleukin 33, again, the list goes on. The reason I'm saying this is because in the typical allergic reaction, and I use allergic asthma as an example, you have these two phases, the immediate phase and the slow phase. However, triggers such as viruses, such as stress, such as Borrelia in Lyme, such as coronavirus spike protein, will stimulate release of these inflammatory molecules without necessarily triggering the release of histamine and tryptase, etc. So in this instance, therefore, we're talking about a different type of activation. We don't have a name for it as of yet. And finally,
and sorry to cut in again. So okay. These cases are going to look different because they're releasing different molecules.
Well, maybe so. For instance, we have patients that are typically, let's say, allergic, but the only flash on the face they get allergic conjunctivitis, but don't eat. We have other patients who have mast cell activation. They have a lot of gut problems because the intestinal mast cells are activated, but not the cells elsewhere in the body. So when we used to say a mast cell is a mast cell is a mast cell, doesn't hold water anymore. So the mast cells, number one, are different in different tissues. They respond to different things, and their response is regulated by whatever is happening in the environment of the tissue where they actually reside. Now, there's another category, which technically could be part of the first category, but that's alpha hypertryptophanemia syndrome. You may or may not have heard of it, but let me explain why. So the mast cell granules contain tryptase, but the tryptase is actually a tetramer held together. So four different molecules. And those molecules are beta-2 molecules. The structure is called beta-2. In alpha hypertryptophanemia, the tryptase is alpha-2 dimers, not tetramers. They're inactive, and they're not in the secretory granules, but they're being released.
Okay.
And that is a genetic condition. And according to Dr. Lyons, who first reported it, there might be as many as 10% of the population that have high tryptase because of this.
Oh.
Now, this is not mast cell activation disorder or syndrome because the tryptase is not coming from the granules and it's not the beta tryptase. However, even though the alpha-2 dimer is supposed to be inactive, 50% of the patients have symptoms just like a mast cell activation patient.
Okay.
So go figure. You see how complicated.
Yeah, wow.
So we should be focusing on mast cell activation. How do we define it? How do we measure it? What do we do about it? Rather than getting hung up on MCAS specifically.
Got it. So maybe I'll rephrase the question I was going to ask you, which is, how would the typical person with mast cell activation present? Like, say someone listening right now and they've got a whole bunch of symptoms and they have no idea what's causing them. What should they look for?
Okay. It's an excellent question. Most of the people with mast cell activation, or specifically MCAS, would respond to stimuli other than the typical allergen. So in allergy, it is the immunoglobulin E that is produced, sits on the surface of the mast cell and waits. And when an allergen to which the IG was made comes and bridges two or more molecules that look like a Y, basically, then a series of reactions takes place that leads to degranulation. And we call that atopic disease. So by definition, atopy is only when IgE is involved.
And that just to, again, clarify, that's like people who have the runny nose and the sneezing and the red eyes.
Correct. Now, once you start having people responding, whatever the symptoms might be, to smell, to pressure, to heat, then we're really talking about mast cell activation and not allergies. Therefore, and mast cell activation patient is likely to have symptoms way over and beyond either a food allergen or an aero volatile antigen. So I've had patients, and I travel with patients, and we'll get off a plane in another country. We're forced to go, as you know, through duty free. And they smell like 30 different perfumes. Yeah. Literally, they fainted. Wow. And not only they fainted, but they go into a psychological reaction that a number of patients have called mastocytosis, because they get absolutely, I want to get out of here. They get angry, they get combative, etc., which basically indicates, as we might have time to talk about, that mast cells of the brain are also very active as they are.
Maybe this would be I was going to ask you about the neural or psychiatric manifestations. And most people think of allergy as just affecting the body. They get a rash, they get hives, they get the runny nose. But, one of the papers that I first read of yours was your paper on neuropsychiatric. Of course, being a psychiatrist, I was super interested. So because people might have changes in mood and alertness and things,
they absolutely do.
Mast cells are involved.
Yeah. So first of all, let's go simple. Anybody who has actually eczema and they're scratching themselves from morning to night, they're going to have psychiatric manifestations. They're going to get anxious, they're going to be upset, they're going to be angry, the works. But we're talking more than just that. So I dare say, I published a paper in 1990, I called the mast cells the immune gate to the brain. And at that time, no one believed that the mast cells do anything in the brain.
Right.
Now we've come all the way to Dr. Alfred and colleagues just published a paper about neuropsychiatric aspects of mast cell activation syndrome. He had published a similar paper many years ago in the same journal about neuropsychiatric syndromes in mastocytosis patients. So now he's expanding basically the field. So the mast cells have three unique attributes, if you wish, that relate to the nervous system. And I published a paper last year about the role of mast cells in the autonomic nervous system that reviews a lot of these things. And I'll be happy to send you the PDF, and you can make the PDF available if you wish.
Okay.
So number one is they are not only located very close to blood vessels, but very close to nerve endings, including sensory nerve endings in the periphery. That's number one. And in fact, a paper was just published in the Journal of Allergy, Clinical Immunology this week about the role of the nervous system regulating inflammation in the lungs, in asthma, for instance.
Sorry, just to cut in again, if the mast cells are close to the sensory nerve endings, does that mean they can be involved in pain?
Absolutely, yes. Okay. I have a small video that is actually on the website of the International Academy of Pain Research about mast cells and pain. And I've published actually 2 papers on mast cells and fibromyalgia and pain, and mast cells and migraine. So that's one, sensory nerves. The second is that they're found in the brain in 2 very critical locations. One is they line up basically the meninges that cover our brain. We have 3 sets of meninges. So it's P, arachnoid, and dura. And those meningeal mast cells are definitely involved in headaches and especially migraines. The third aspect is in the brain, the mast cells are found in the thalamus, hypothalamus, amygdala, and the pituitary stalk, the median eminence that connects the hypothalamus to the pituitary. In fact, we have as many mast cells in the pituitary stalk as we have in our skin, yet the brain doesn't get allergic reactions. The pineal gland is covered with mast cells. So is the thalamus and the hypothalamus. So the critical part is that the mast cells literally hug the protective blood-brain barrier. So if the mast cell is activated, it will release histamine, tryptase, and other molecules that disrupt the blood-brain barrier and make it now leaky to molecules from the blood or even from the gut to the blood, to the brain, that should never get into the brain. Once that happens, the brain defenders, the microglia, get all excited now, and they try to contain the damage, and they literally cause a localized inflammation in the area where the mast cells allow the blood-brain barrier to open up. So there's no question that the mast cells can participate in sort of neuropsychiatric problems in many different ways. And as you know better than I, in most cases now we talk about inflammation in the brain as being part of the underlying sort of pathogenesis or pathology of many conditions.
And as I'm sure you know, neuroinflammation is really, everyone's talking about it now in fibromyalgia and ME/CFS and long COVID. If someone listening has a bunch of, we'll say, cognitive or mental health symptoms, which ones are most likely to be an indicator of neuroinflammation and or mast cell connection?
Brain fog.
Brain fog. Oh, dear.
So difficulty with cognition, literally something similar to minimal cognitive impairment.
Wow.
Which is kind of the beginning, as you know, of dementias. And many mastocytosis patients have been telling us this for years. They just cannot quite, multitask. They can't find the right words, etc.
Yeah.
And everybody Brucha had it. I remember I gave a lecture on neuropsychiatric symptoms of mast cells here in Boston when they were starting up a center of excellence at Harvard for mastocytosis, and my colleagues didn't believe it. I mean, they were there and they were kind of, could see their faces smirking about what I was talking about. And, we're picking up. Unfortunately, it took about 20 years for us to catch up, and we're not quite there yet. Same thing happened with symptoms like many patients have headaches, but headaches can be a category in its own. Obviously, migraines can be, but they go hand in hand. Very often, they complain of headaches.
Oh, interesting. So headaches, brain fog, anything else? Those are the big two, I guess?
The big two, except for those that relate to the mast cells, but they might not be all together. Most of the time, I see flushing, erythema on the face and the torso, especially when people get upset. The heat and stress are the worst offenders. And we published a series of papers that the first molecule released, the first hormone released under stress, corticotropin releasing factor, CRF, we always thought that is released in the hypothalamus, stimulates the pituitary adrenal axis. Well, we and others have shown now numerous times that CRH is released in the skin, in the bladder, in the gut, and it is pro-inflammatory rather than being anti-inflammatory by stimulating steroid release from the adrenals. Not only that, we published 2 papers where we showed that the mast cells contain and release more CRA than the hypothalamus per unit volume. So you see, we're having a cyclic reaction, basically. So, for anybody who says, oh, it's all in your mind, well, yes, it is in my mind, but I know what is happening, rather than drive me crazy because, you don't understand what I'm telling you. I don't mean you, of course.
So just to take a step back, I guess I have 2 questions going in different directions. The first one is, how do people get mast cell activation? It seems like it's much more common than it ever used to be. Do you think that's true? And if so, why?
I would say yes and no. One reason why more discussed, if you wish, is people like Dr. Afrin, like myself, and others talk about it. Before, I don't know, 10 years ago, hardly anybody spoke of mast cell activation. Everybody was focusing on mastocytosis, which is an extreme case. So recognition and information is important. The second is that many times we have seen mast cells that might have been otherwise quiet. Someone might have some allergies, allergies, whatever. And they undergo a major stressful event. It could be major surgery, car accident, God forbid, someone dies in the family. And very often after COVID, and also after vaccines for COVID, now individuals say, I'm allergic to life, quote unquote allergic, because I don't know what to call it. So it seems like the mast cell reactivity is being reset by things we're exposed to, some of which we understand and others that we don't understand. For instance, as I'm sure you know, one of the most common herbicides is glyphosate, which says as Roundup. Now, not only glyphosate has been shown to affect the brain, but we published that it stimulates the mast cells. Yet everybody sells it, and you go out in your yard and everybody sprays your yard with glyphosate. Not only here, in Europe as well. So here's an example of what we know we're doing bad things to ourselves, and yet, we, as a medical profession, let's call it that way, don't really try to curb it. I mean, all it would take for something like this is a presidential degree. Yeah. The president would say, enough, out. And yet they're not doing it. The second is, we and others have shown that mycotoxins that are volatile, that are released from mold, stimulate both mast cells and microglia. And especially here in Florida and in Texas and in a few places, probably in Canada, we've had floods upon floods upon floods. Yeah. No one's really properly remediating this. And even if they were to remediate, the mold that might be visible. Mycotoxins stick to everything, carpets, rugs, clothes, etc. And I'll remind you, I wrote a small editorial about this, and I referred to the Old Testament. The rabbi in Old Testament says, if you walk into a moldy house, you tear it down and you burn your clothes. So they knew much better than we do, in spite of all our scientific, information.
That's amazing.
So these are potential new things that maybe we were not aware of, and they don't. And there's no question that preservatives that we use in food are horrible. Give you an example.
Okay.
Which surprised me to no end. Our gut makes all kinds of small fatty acids. And one small fatty acid is propionic acid. And some colleagues of yours in Canada had shown many years ago that if you inject propionic acid intracerebrally inside the brain of mice, they become autistic, whatever an autistic mouse is. They change themselves, they bite their tails, they don't rub their noses, etc. Well, it so happens that propionic acid is found in about 50% of foods and supplements as a preservative. But no one is telling you that unless you ask for the certificate of analysis, in which case they'll have to disclose it. And in fact, there's so many preservatives that we use that sometimes we are aware of the damage we're doing, sometimes we're not. So I urge anybody who will be using anything at this point to be looking, if possible, the fine print. What are the inactive, quote unquote, ingredients?
Right. So let's just go back a step. Thank you for following. So basically you're saying if there isn't, that part of the increase may be due to increased awareness, but also it could be our increased exposure to this really wide variety of toxins.
Correct. But it may also be the fact that about, let's say, 50% of people with chronic urticaria are not managed by antihistamines. So we've had those patients over the years because they didn't know what to make of them.
Yeah.
Well, now they're shifting into this new category where we say, well, they're activated by other things, and they release other things, and that's why the antihistamines don't help. So I think it's not only awareness of the diagnosis, if you wish, but awareness of the fact that many patients that didn't fit the previous diagnosis, and now we have to fit them into a new one, otherwise it doesn't make sense.
Okay. Can you just go back and talk? So you talked about the brain symptoms. Let's see if I can remember them. So brain fog, headache, and flushing and sensitivities.
Correct.
I'm guessing poor sleep.
Sleep definitely, but
pretty big.
Sleep, dysfunctional sleep can be to so many different things.
Right.
Like in myalgic encephalomyelitis, chronic fatigue syndrome, dysfunctional sleep is one of the biggies. And they don't necessarily have other symptoms that I would ascribe to mast cell activation.
Yeah.
So it's hard to call it. Yeah.
But yes. What about some of the more physical symptoms? Like you've talked about triggers. There's triggers. Maybe I think you said heat and stress and infection.
Correct. And infection by anything.
Temperature. Yeah.
So in some individuals, it might be flushing. In others, it might be itching. In others, it might be bloating. It might be abdominal pain. So a paper was published in the journal Nature 3 years ago, where they showed very convincingly that even just histamine released from intestinal mast cells sensitizes the sensory nerves in the gut, and that is perceived in the brain as colicky pain, abdominal pain, just that alone, without necessarily any other problem. And the mast cells in the gut are actually very important, but very poorly understood. And that is because you don't know where to biopsy to look at the mast cells. I mean, in the skin, you can biopsy if you have cutaneous mastocytosis. So most of the time, the gastroenterologist will scope, and they cannot see anything. So there's nothing there to biopsy.
Right.
Dr. Miner from down south had published a number of papers that if you're going to go blind, the ileocecal junction is the place where most of the mast cells are likely to be. Otherwise, you do some blind biopsies. And I always say, if anybody has to do it, they have to stain with two stains. They have to stain for tryptase, and they have to stain for c-KIT, which is on the surface, which is basically an enzyme, because the c-KIT is always on the surface, so it's going to pick up all the mast cells. However, if they use tryptase and the mast cells are degranulated, the tryptase would have come out, they'll never count the cells because there's nothing there to count. So by doing both, you get an absolute number of mast cells and a rough percentage of how many of the mast cells have actually been granulated. So,
and just what you just said about the manifestations in the gut, and that the gut, my understanding is the most mast cells in the body are at interfaces with the environment. So the gut obviously is a big one. Could that explain why some people get IBS? Like, we've described IBS as a pain disorder, but now you're saying, oh, but the mast cells might be sensitizing those neurons.
I wrote about the role of mast cells in IBS about 20 years ago.
Okay.
And in fact, I wrote in editorial that mast cell activation is more important than numbers. Because going back to what we started speaking about today, if the mast cells release these inflammatory cytokines without degranulating, they're not going to change in numbers, but the outcome will still be having an effect, obviously. So in other words, you can have 100 mast cells doing nothing, or you can have 50 mast cells going crazy. Well, the latter is going to cause problems, not the former. Yeah. So that's why I actually recommend for anybody that has gut problems to do a stool analysis for the following three. Total histamine. Because if the histamine comes from elsewhere in the body, it gets broken down within 1 minute, and then you have to pick it up in 24-hour urine as N-methylhistamine. If it's produced in the gut, it's not methylated, you're going to actually measure it.
And is this a stool test?
It's a stool test. So send stool for total histamine, eosinophilic cationic protein. As you know, the eosinophils go together with mast cells, especially in cases of parasites and allergies. But the eosinophils, again, can be normal in the blood, but they can be releasing this eosinophilic cationic protein, which stimulates the hell out of the mast cells. So if this is high in the gut, it's telling me indirectly that the mast cells are being involved, and maybe I should look for parasites or something else. And the third one is calprotectin, which is a molecule that is an index of inflammation, much better than erythrocyte intimidation rate or C-reactive protein. So that is telling me if something is happening in the gut, and I should focus primarily on the gut rather than somewhere else.
And without maybe encouraging you to endorse any particular lab, where would, suffice to say in Canada, these aren't routinely available. So people would have to have a lab and, send the samples usually to a private lab.
In the States, LabCorp and does it, Genomics does it too. I don't know if there's Genomics in Canada, but Genomics does do the stool test.
Okay, that's great. And so you've talked a little bit about diagnosis. So you've talked about the blood test, but that sometimes the tryptase is really hard to catch. So even if you're negative, probably some treatment trials are still recommended. Like, you shouldn't just give up if you're negative.
No, absolutely not. After all, in my book, the only way to treat any of these problems is to block the mast cells, because it will block a release of histamine, release of tryptase, and release of who knows what else is going on. So the usual treatment approach, and it is the same whether you have mast cell activation unspecified or mast cell activation syndrome or indolent systemic mastocytosis. It's the same. Where it changes is in aggressive systemic mastocytosis, where we have drugs that block basically the proliferation of mast cells.
Right.
To be more precise, they cause apoptosis. They cause the mast cells to basically drop off and die, and therefore they don't multiply anymore. And hardly ever in indolent systemic mastocytosis or mast cell activation. So the usual treatment approach would be to choose at least one antihistamine of the type 1, because there are 4 different histamine receptors. These are the typical ones we use for itching. It could be cetirizine, it could be Benadryl, it could be Allegra, it could be Rupatadine, which exists in Canada and not in the States, Rupal, etc. And 3 points I want to make with the antihistamines. Number 1, not everybody responds the same way. So unless you've tried up to 3, don't give up. So if you try, let's say, cetirizine doesn't work for you, that doesn't mean to say that others will not. That's one. Second is that they're supposed to be non-sedating. But if you push the concentration, then they become sedating because they get into the brain. So the second step is we can go up 4 times the original dose, keeping in mind that when we start reaching 4 times, we'll start getting sedating.
And so the typical dose for these longer acting ones is, I know they're not all the same, but it's usually twice a day to take it because they last for 12 hours.
So for instance, cetirizine, Rupatadine, Allegra, etc., they're 10 milligrams a day, and typically we'll start with 1 a day and then go 2 a day, but you can go 4 a day.
Okay.
However, once they start getting into the brain, or I should say, once start pushing the concentration to 4 times normal, number 1, all antihistamines also have anticholinergic effect, and they put someone in urinary retention. They might not be able to go to the bathroom anymore.
Got it.
Because acetylcholine, as you know, constricts basically the detrusor muscle, opens up the sphincter, and allows us to urinate. So there we have to be careful. Also, I never go 4 times the dose or higher if someone has seizures, because the higher the amount of antihistamines, you're likely to actually either reduce the seizure threshold or exacerbate seizures. So and I worry because some of my colleagues give 150 milligrams Benadryl. I'll never give that unless you're in a hospital setting and someone can watch. Now, what do we do after that? So then you say, well, what else do the mast cells release? They release prostaglandins. Will I give someone aspirin? Well, we worry about the aspirin because you can exacerbate asthma. So we shy away from that.
Okay.
They release leukotrienes. Well, leukotrienes are primarily bronchoconstrictors, but some colleagues say, well, what do we have to lose? Let me add an anti-leukotriene, such as Singulair, for instance, which is okay, except that in some people it causes nightmares. So again, you have to watch it. So between starting the antihistamines and this point is where the flavonoids go in.
Okay.
Now, the flavonoids, unfortunately, have a lot of misconceptions. So first of all, there are about 3,000 flavonoids in nature, and not all of them are useful.
Okay.
I'll give you an example. There's something else as soy flavonoids. But if someone has estrogen-dependent cancer, breast cancer, or ovarian cancer, you don't want to give something that is estrogenic. So in that case, the flavonoids, isoflavonoids, would absolutely be contraindicated. The flavonoids are absorbed less than 10% in powder form from the gut. So many colleagues will say, well, I'll give you 2,000 milligrams a day. Eventually, you'll absorb something. What happens is you absorb about 200 milligrams, 10%. 1,800 milligrams stays in your gut and shuts down your bioflora and your enzymes. So now the ability to detoxify goes to pieces because your P450 system is inhibited, and your gut flora goes to pieces, and now you have dysbiosis, and you start chasing your tail, what's happening with my gut? So that's why many years ago, I formed actually a small company in Sarasota, Florida, called Algonot, ALGONOT, and we chose various unique flavonoids, and I'll mention 2, but we mix them up with olive oil. And when you mix up any powder with any oil, and you shake it or you give it energy or you centrifuge it, it acquires the spherical shape, if you wish. So we call those liposomes, and they trap inside the powder, and the absorption is 3 to 5 times higher from the gut. And by using the olive oil, you get the benefits of Mediterranean diet in a capsule, so to speak. So because many individuals are very sensitive, there's one formulation called Pure Lut that has only luteolin, 100 milligrams luteolin. So 50% of the content is the luteolin, the other 50% is the oil, but all mixed together. The other category is Neuroprotect, because we developed it primarily for individuals that might have, as you discussed earlier, neuropsychiatric symptoms, and that has both luteolin and quercetin.
Okay.
Quercetin and luteolin are very similar, 98% similar in structure. But because luteolin is less phenolic, meaning it has fewer hydroxy groups, and I'll explain this for our audience in a second, luteolin gets in the brain easier because it's more lipophilic, and quercetin is like a decoy, gets basically metabolized in the liver and allows the luteolin to escape and get into the brain.
Oh, I see. That's pretty clever.
Thanks. So patients tell me, well, how do I know if I have phenol intolerance? Well, if you get hyper when you eat chocolate, strawberries, berries, grape seeds, that's phenol intolerance. Unless you do genetic analysis, in which case we can actually find it genetically. But if anybody tells me they get hyper, they get wired, then I go very slow. And then we start with Pure Lut or just luteolin.
Yeah.
Then you can migrate to Neuroprotect. And for individuals that are also very tired, and many individuals are very tired, especially fibromyalgia, chronic fatigue, we have Fibroprotect that contains also coenzyme Q10 and L-carnitine to give you a little more energy in the mitochondria. Okay. Just giving you some examples, basically.
And how does the luteolin, because I've looked up some of your websites and papers, you've really done a ton of research on that one. Okay. How does it actually help? Like, it
shuts down the mast cells and it shuts down the microglia in the brain, deactivate it. So what we do is every day we culture in the laboratory human mast cells and human microglia. We stimulate them either with triggers that we know or suspect and measure the outcome. The outcome could be cytokines, histamine, tryptase, and one molecule that I'll mention in a second. And then we either pre-incubate the mast cells to see if we can prevent the release, and then we can block 100%, I know that. Or we try to post-treat and see if we can reverse the reaction. Post-treating is a little more difficult because the mast cells, within a few hours, restock their granules. Right. So you almost have to have some luteolin there all the time to keep the cells from firing rather than reversing the case. And one enzyme that we showed recently that is unique, especially for neuropsychiatric symptoms, is called MMP9 or matrix metalloproteinase 9. It's basically an enzyme that remodels connective tissue, if you wish. Right. But what is important, especially in the brain, is the brain needs the scaffolding for nerves to crawl and make connections. And that scaffolding, interestingly enough, is primarily made from chondroitin sulfate, the same chondroitin sulfate we have in our joints, which kind of blows your mind, if you wish. Well, we showed, to give you an example, that MMP9 is very high, and we published this in children of the spectrum, autism, in individuals with ME/CSF, and in individuals with long COVID. All of these are published in very good journals.
Wow.
And the good part is the luteolin and the quercetin, especially in combination, they shut the release of MMP9 from both mast cells and microglia. So there's a lot of science to back up. Unfortunately, what has happened is ever since we started publishing and making these formulations available, there are 20 companies selling luteolin or quercetin out there. And it is amazing. They'll say 100 milligrams, let's say luteolin. And then you read smaller letters, well, you have to take 20 capsules before you reach 100. Or it might not be luteolin enough purity to make a difference. So in Albonaut, there are 3 pluses. One is that it is registered with the Food and Drug Administration. Supplements are not mandated to be registered in the United States. I don't know about the Canadian Health Authority. That means that the FDA inspect the algonaute every 2 years, and they can actually just pull a supplement off the shelf and request all the certificate of analysis of every ingredient, active or inactive. Less or fewer than 10% of compounds in the United States are FDA registered. The second is that everything is analyzed independently by a laboratory called Eurofins in California. So the active ingredients before they go in and the final product are analyzed, and unless they're within 10% of what is in the label, they're not released. And the third, which may not be known by a lot of people, is even though the United States cannot regulate supplements by a law of 1994, if you wish to export it and you ask the FDA, want to inspect it, to get the certificate that is good manufacturing practices patiently formulated, there's an independent source for the purity. The source is the right source. And you have at least one open label study. They give you a certificate of free sale. It says FDA, it's got a golden seal on it, and it's actually renewable every 2 years. And all the algonaute products have that.
Okay.
So the reason I'm saying is we can raise the bar. And I'll tell you, Amazon has decided to do something that absolutely blew my mind. As of April 1st, they mandated that all supplements that are sold on Amazon have 1 year to comply, showing independent analysis of the purity. Something that the FDA should be doing and Amazon is doing.
That's amazing.
It is amazing. But they're picking up, random samples until they catch up. They might never catch up, but I'm just saying.
Right. Wow. That's really good information. And so what is the dosing of, let's just stick with the luteolin, because that seems to be kind of the real premier product.
Correct.
Would someone start with just a piece of a pill and work up, or what do you recommend?
I always say, especially if I don't have access to the patient directly to be able to converse, I would say start with one for a few days, then go one in the morning and one in the evening for a few days, and go up to 2 and 2 and let it go for 1 to 3 months.
Okay.
And if you see benefit, then you can increase it. But I never say go more than 8 a day.
Okay.
Just even at 8 a day, we're below the level that would worry about inhibiting enzymes. And we often get the question, meaning the patient, asking, I did gene analysis and I have P450 mutations and I cannot metabolize product very well. Can I take this? And my answer is, don't go more than 2,000 milligrams a day of any type of flavonoid combined. It could be pycnogenol, curcumin, luteolin, quercetin, whatever. And one confusing aspect of many of these formulations selling is they call them immune boosters. Right. Well, if I have inflammation, I don't want to boost my immune system. I want to shut it down or regulate it. So the idea that the flavonoids are immune boosters is entirely wrong. They're regulating or maybe inhibiting, but definitely not boosters. Okay? So, but the people out there think that if I boost my immune system, everything will be hunky-dory. Well, most of the autoimmunities are due to such problems.
I know. I learned long ago that if I take things like mushrooms or other products that are immune boosters, my MCAS symptoms go berserk.
Right. Well, immune boosters might be important. Let's say, God forbid, if you have cancer and you want to stimulate, let's say, your natural killer cells or something like this to start chewing up the cancer cell. It's just that it's not for everybody. That's all.
Do you have any, this is kind of a ringer question, but do you have any thoughts about fermented foods and probiotics? So those also make my symptoms go berserk. And I wonder if it might be due to MCAS.
Absolutely, yes. So fermented foods contain a lot of histamine, as cheese, avocado, tomato, spinach, sauerkraut, sardines, and all spices, especially cumin. Pineapple has a lot of histamine as well.
Okay.
So one tries to avoid those. And beer is a big one because it's fermented, as is red wine because it's got the tannins that stimulate the mast cells. Now, there's one set of probiotics that are uniquely useful.
Mm.
And those are the species called Can you stop for a second?
Yeah. Just take your time and we'll edit it out afterwards.
There's one. We're back.
Yeah.
So it's called bifidobacteria.
Mm-hmm.
So there are many species or subspecies. The best ones are bifidobacteria infantis and longum.
Mm-hmm.
But all of the bifidobacteria inhibit production of histamine in the gut. So therefore, we have a benefit there. Not only we're getting a probiotic for all the right reasons, but actually keeping histamine quiet. I doubt it very much if the bifidobacteria are going to bother you or anybody else. Where I worry is if someone is either truly allergic or sensitive to milk products, such as casein, lactoglobulin, because the lactobacilli are made from milk. In those individuals, I try to avoid any probiotic that has lactobacillin.
Got it. Okay. So if you were seeing a patient coming in, you've determined from the history they have these flares of symptoms that are very suggestive of MCAS. How would you approach them?
I saw actually 10 patients like this last week.
Okay.
Varying at different levels. And one was very, very actually interesting. I might mention one without a name, of course.
Sure.
So first of all, I need to do a set of tests to make sure that I'm not missing any. And those tests will be total immunoglobulin E and total subclasses of immunoglobulin G, G1, 2, 3, and 4, especially because immunoglobulin G4 is involved in food intolerance. So we have many patients who turn out to be not allergic to anything, yet with a food intolerance test, they're positive. Now, many colleagues don't like doing a food intolerance test for the following reason. If you eat something every day, it turns out to be false positive. So you almost have to abstain from pretty much anything for about 2-3 days and then do the test. So I usually say boil organic chicken and quinoa. Quinoa doesn't have gluten in it, so at least, I deal with that. And then chicken, I've never seen really anybody respond, to be honest, to chicken, unless they're preservatives. So, so those two. Then, some colleagues measure histamine in the plasma. It's okay to measure it, but in most cases, it will be destroyed and we'll find it in the urine. The only time I've seen elevated plasma histamine is individuals who have an autoimmune condition where they make antibodies against the IgE receptor. And these antibodies are what we call gain of function. Rather than blocking the receptor, they stimulate the receptor. And there is a test, we call it either Ig receptor antibody test or basophil activation test, because you can't isolate mast cells from the patient, but you can get their blood, isolate the basophils, and the basophils respond to Ig just like the mast cells. But the basophils don't respond to everything else that the mast cells respond to in mast cell activation disorders. And sometimes it's hidden. For instance, if you go to Quest, if you look for, let's say, basophil activation test, you can't find it, but it exists under, for some reason, urticaria panel number 2. I don't know who made a panel, and they buried it.
And so say when you move beyond the testing, or maybe, you couldn't get the tests and you just want to start treating to see if things get better.
I would do everything we discussed earlier.
Yeah.
So some antihistamine after trying, 2 and 3, then add a histamine. I didn't mention, but we should be adding a histamine type 2 antihistamine, such as ranitidine, for instance, or famotidine. Because anybody that has a chronic condition are likely to be causing a little gastritis. So you're going to prevent that. And there's a recent paper that the mast cells contain histamine 2 receptors on the surface, just like the parietal cells in the stomach. containing histamine. And the histamine 2 receptor on the mast cells stimulates the mast cells. So by giving a histamine 2 blocker, we might get two birds with one stone. Protect the stomach and reduce the reactivity of the mast cells.
Okay.
Then I'll go flavonoids.
Okay.
And keep on increasing until we can actually, with a combination, block most of the symptoms. And I tell patients not everything fits in one basket. So I'd like to see within a month and at least until 3 months have gone by, what have gotten better, improved, and what is not. Because certain things might not improve, and then they might force me to look either for other ways to address it or some other reason as to why they're there, and I missed it altogether. Give you an example. More and more we're picking up what is called alpha-gal syndrome. So alpha-gal is a molecule that is found in all of the mammalians. But in humans, for some reason, we have not been sensitized to it, so we have it. If, however, we're bitten by a tick, regardless of whether we might get Lyme disease, Borrelia, Babesia, or whatever else, that carries now alpha-gal to us, and we become allergic to it. So I've seen lots of individuals that come with what's supposed to be burning tongue syndrome, and they're red around their mouth, and basically it's because of alpha-gal. And alpha-gal, it's found in pretty much any mammalian product that is used everywhere, drugs, cosmetics. So I've seen people using mascara, and they'll turn red, and it's because of alpha-gal. But the good thing is that alpha-gal can be tested. Both LabCorp and Quest and a few others do it. So anybody, I suspect anybody, especially if it's out in the woods, that might be bitten by tick, but they don't have arthralgias, and especially if they get red around their face, or they eat something. Yeah. I've seen people react with just chopstick or lipstick, and they will react, for instance. So.
Oh, that's fascinating. That's totally new. I love learning new things. Just to wrap up, sure. I know you had said in an email you wanted to address some of the common misunderstandings about MCAS. Yes. What are some of those?
Okay, so maybe we can wrap it up by saying, first of all, Dr. Stein, it's wonderful to be with you, and I appreciate it. I'll be happy to come back.
Thank you. Because there's so much. Obviously, you're just giving us the taste of the complexity. Yeah.
So take-home messages are the muscles are everywhere in the body, and they can respond to numerous triggers unrelated to allergies, and the symptoms can be very confusing. Number 2, antihistamines only touch the tip of the iceberg, and many of the other symptoms that might be due to a whole bunch of other molecules being released are just missed altogether. Number 3, if you go and visit a physician, especially if you're a woman, don't put makeup, don't look nice, don't sleep for 3 days. Go in looking disheveled and just say, I've got 3 horrible symptoms. If you go in there looking nice and talk to them about 20 symptoms, they're not going to believe you. And you're not going to get through the door. You really have to get someone's attention. I mean, the same might be true for men, but usually it's more likely for women. The other take-home message is that we have to block the mast cells. We have no drugs to block the mast cells. The only drug is called cromolyn, and it's miserable unless it helps someone, in which case, obviously we'll use it, because it's absorbed less than 5% from the gut. The body gets used to it very quickly. We call that tachyphylaxis. So you have to we start at 100 milligrams a day. By 4 months, we're 400 milligrams 4 times a day. That doesn't work. And once you reach that level, you start getting 50% diarrhea and about 10% alopecia. Okay? So we have to be aware of it. And for some reason, the company that sells cromolyn in the United States changed its formulation a few months ago, and everybody's reacting to it. They cannot tolerate it. So they must have put some preservatives in. Everybody's writing to them, but they haven't pulled it from the market yet. So we have to be very careful. However, if you have allergic rhinitis, there is a product that has cromolyn for a nasal spray. It's called nasal crom. That I find quite useful, if the symptoms are primarily kind of from the face.
Okay.
If we block the mast cells, some flavonoids in what we call liposomal form, mixed with oil, such as quercetin and luteolin, such as in the Pure Lute or Neuroprotect or Fibroprotect, are very useful, but it takes a few weeks to just calm the mast cells down. they don't act like an antihistamine. And they can be used with antihistamines and anything else. And finally, if you suspect that your abdominal cavity, so to speak, is bloated, and I say that because you might have an enlarged spleen, you may have an enlarged liver. For a lay person, it's hard to palpate and realize what is going on. Those are added signs, along with tryptase, that one may have mastocytosis. So if someone's tryptase is high and they feel like the spleen and the liver are enlarged, they really have to see someone. Okay. And in those cases, they do deserve a bone marrow biopsy. But that would be the extreme, but I don't want to exclude it. Now, in between, there is a test that we haven't actually spoken about, but when we get blood cells, we can do what is called flow cytometry. You can separate the cells according to what they have on the surface. And the mast cells that are likely to be associated with mastocytosis will have more c-KIT, more CD25, more CD3, 3 different molecules. The flow cytometry can identify those. If, in fact, there's a high number of such precursor cells, that would indicate that most likely we're dealing with mastocytosis as well.
Much less painful test than a bone marrow biopsy.
Absolutely.
Yeah.
Absolutely. I agree. And by the way, if anybody goes for bone marrow biopsy and someone tells them we'll do an aspiration, tell them absolutely no and walk out. The shearing forces of aspirate will degranulate all the mast cells. So you'll not be able to see anything.
Okay.
So,
I think I'm gonna wrap it up there because we've already gone a little bit over. I'm super grateful. You've just packed so many very useful tidbits in this for the people listening. So thank you very much.
The easiest site to follow, it's Dr. Theoharides, Theoharides.com. Because I've got a whole bunch of rubrics and links to other things, links at the university, links at the company Algonaut, and most importantly, pretty much everything I've published is free as PDF files to be downloaded from there.
That's fantastic. So we'll definitely include that link in our description. Thank you very much.
Thank you so much, Eleanor.
Thanks for joining me on the Dr. Eleanor Stein podcast. I hope you are taking away new strategies and ideas to improve your health and a renewed sense of hope. Join me, Dr. Eleanor Stein, for our next episode. Can't wait? Check out my website for a wealth of free resources.